Hey, thanks so much for joining us for Georgia MemoryNet Insights. We're really excited that you're here today. We're going to give folks just a minute more to assemble, and then we'll start in just a second. Thanks for joining. We'll start with an introduction. So Dr. Gaster has all of his time available to speak. We're so glad to have you, Barak. And every year we have the opportunity to invite two experts from out of the state of Georgia. And so we're so glad to have you here this month as our national expert with us at Georgia MemoryNet Insights. And so you are an internal medicine physician. You're a professor at the University of Washington. You did your MD degree at University of California, San Francisco, and your residency and chief residency training at University of Washington. On the national level, you're very involved in the Gerontological Society of America's Kickstart, Assess, Evaluate, and Refer Toolkit, which is a great startup guide for folks who are in primary care settings to figure out what are some of those next steps. I'm particularly interested in having you here today because for you as an internist, you are very thoughtful in your practice and teaching about what to do with patients who are coming in with memory concerns and how to look at the medical and psychiatric problems that you could deal with in a primary care setting, such as depression and sleep and medications, and what you can do with in fixing those conditions and making people better. So thanks so much, Dr. Gaster. We're going to turn it over to you, and I'll watch the chat and other Q&A areas and keep you apprised as to how we're doing. Thanks again for joining us.
All right, thank you so much for having me. And again, my name is Barak Gaster, and I'm a primary care doctor through and through, general internal medicine, but for the past 8 years or so, have also really been focusing on becoming an expert on dementia in the primary care setting. And, this topic, fixable factors of cognitive impairment, is so, maybe the most important thing to really get a handle on in primary care, because these are the kinds of things that, it's just like, it's so sad for us to refer somebody to a specialist and have them wait 9 months to have these things sort of assessed. And so these are the simple sort of things that we really can do to make a difference in primary care. And so without further ado, I have no financial conflicts of interest to disclose, and you can for sure get CME credit for this. And so I think we have a poll now.
Yeah, thanks so much. This poll helps us in terms of targeting our content. And so just go ahead and answer by discipline. And this gives us an idea. And I'll turn it back over to Kim to finish the poll once everybody's had a chance to weigh in. And Brock, you and I can't answer the poll. I've already tried that once. All right, Kim, go ahead and end the poll. We'll be able to see it. It's mostly physicians with some PAs, NPs, RNs, and PhDs.
Great.
So thanks so much.
All right. And so without further ado, the three parts of my very brief talk this afternoon is we're going to talk about triggers for action. We're going to talk about doing cognitive evaluation. But really most of the time today, we're going to be talking about these factors that we really can easily address in the primary care setting. And, because this is what Ted wanted me to focus on, this is going to be really the main focus of this presentation. But I do want to take a second to just talk about, like, what are these triggers for action? When should you be thinking about looking for these fixable causes? And so it could be a patient or family mentioning a concern. It could be an abnormal score on a brief cognitive screening test, such as at an annual wellness visit, or it could be at an annual wellness visit in the health questionnaire. Your clinic may have a question. Do you or someone that you know have a concern about your memory? And so a yes on that questionnaire, or an abnormal score on a brief screener, or a patient or family mention a concern. These are all reasons to really be thinking about, I really want to delve in and understand, could there be a fixable, addressable cause of their concern? And the most important thing to think about for primary care is that I really want to sort of encourage you to feel absolutely sort of confident and justified to schedule a separate dedicated cognitive evaluation visit. So this is going to be a visit where you're not going to be talking about their knee pain or their diabetes or their hypertension. This is really just for evaluating their cognition, which is not necessarily easy for us to do in primary care, but this is a relatively complex task to take on. And so I really would highly recommend setting it up as a dedicated visit just for that. And the other sort of giant sort of tip is to really try so hard to have either a family member or close friend come to that visit. Even the world's best dementia experts has trouble really doing a comprehensive assessment of somebody's cognition without having somebody there to sort of give you some input on how they're navigating through the world. And the three parts of that cognitive evaluation visit are the interview with the patient and family member, assessing cognitive function, such as with the Montreal Cognitive Assessment Test, and then the cognition checklist, the factors that you can fix, easily addressable causes, which is really going to be the main focus of today's talk. And so for that, I really encourage having some kind of a checklist that you can either create in your EHR as a simple a text-based checklist, something that is just going to help you to kind of make sure you don't miss anything. And the main four things on that checklist that I recommend are the lab tests, which are easy to do. And this is probably this is like actually the only thing that I learned on this topic when I was in medical school 25 years ago, which was, don't miss B12 deficiency or hypothyroidism. But without having it on the checklist here, I can tell you that I myself have forgotten to do this. And so really having a checklist with these, with the lab tests on it is a really important, useful thing to do. We're going to talk about medications, we're going to talk about alcohol and drugs, and we're going to talk about conditions, other problems that affect cognition. So these are the four main categories of easily addressable causes of cognitive impairment that are not neurodegenerative cognitive impairment, but are easily addressable things in primary care. And so just to spend a minute talking about medications, here the most important ones to think about are sedating medications like opioids and benzodiazepines. And this might be somebody who for years they have been on clonazepam and you felt a little bit uncomfortable with it, but it didn't seem worth sort of making a big giant rocking the boat. But now that they're in their 70s and 80s and they are either sort of scoring abnormal on a screening test, cognitive screening test, or are reporting that they are concerned about their memory, this really is a moment where you can say, I think your brain really would work better if we could try to reduce the dose of your benzodiazepine or maybe even stop it altogether. Same with opioids. Ambien is probably the most common of these, which is less sedating, less of a cognitive impairer than benzos and opioids, but is still worth considering trying to get somebody off of Ambien as well. But really, like the big giant elephant in the room is the anticholinergic medications, and actually the over-the-counter sleeping aids, such as Tylenol PM or many other brands that have that first tier of antihistamine, which are very sedating. So they work pretty well as sleeping aids, but they are also very, very strongly anticholinergic. And so somebody who's in their 70s and is concerned about their cognition, or you're concerned about their cognition, you can tell them, you may have read on the news that getting more sleep is good for your brain, and that's why you should be taking a sleeping aid like Tylenol PM. But I can really tell you with a lot of confidence that that medicine is probably doing your brain more harm than good. And so really thinking about a safer sleeping aid such as melatonin is really going to be an important step to take. But you've got to ask about the over-the-counter sleeping aid because it's not going to be on their medication list. Such an important part of your checklist for easily addressable causes. And then alcohol and drugs is probably the most commonly missed sort of easily addressable factor, because this is somebody who has maybe been drinking half a bottle of wine their whole life, or having 3 to 4, maybe even 5 drinks a day in a way that has never functionally impaired them before. So they may have not exactly met criteria for an alcohol use disorder in the past. But now that they are in their 70s or 80s and you or they are worried about their cognition, you really can say that I am concerned that whereas that amount of drinking may have been sort of mostly okay for you before, it is now really seriously potentially affecting the functioning of your brain health, and by reducing even that sort of moderate amount of drinking really can make a difference in people's cognition. And then, I think we are increasingly in a world where people in their 70s and 80s are using other drugs as well. And so I would say that marijuana probably fits in the same category, as well as other illicit drugs as well. And then the three main conditions that I would really highlight as, these are the comorbidities where when we treat them or we improve the treatment of them in primary care, we really can improve people's brain health. And so that is treating depression, treating sleep apnea, having people wear hearing aids if they have hearing loss. These are the three top comorbidity conditions where, this is solid, concrete stuff that we can do in primary care to improve people's brain health. And so, this is the checklist, the labs, the medications, alcohol and drugs, and the conditions or comorbidities. And then you kind of put these three things together. So you put the cognition checklist, the addressable causes, factors you can fix, together with the interview that you did of the patient and family member, together with the assessment of their cognitive function, such as with a Montreal Cognitive Assessment Test. You put these three things together, and that is a pretty darn good cognitive evaluation that you can do in primary care, that you don't need to refer somebody to a specialist for, that you will dramatically improve the referrals that you send, because without doing these three things in the primary care setting, I think that the biggest pitfall is sending a lot of people to a specialist who don't have cognitive impairment. So they're concerned about their cognition, but it's really kind of normal things that happen as people age, or it's easily sort of addressable things that you can sort of fix in primary care before sending them to a specialist, that really can improve the flow of referrals to a specialist. And so I just want to take a second talking about sort of like what the diagnosis is, that you put those three things together to make a diagnosis of either mild cognitive impairment or dementia in the primary care setting. So here I show what that syndrome spectrum is. And then, that overlies the etiologies, the things that can cause that syndrome of cognitive impairment. And you'll notice that these four bubbles overlap, because in many ways, the most common form of dementia is actually a mixed form where people have features of more than one of these etiologies. And so just to take a second to talk about mild cognitive impairment, usually the MoCA is low, but their activities of daily living are intact. That's a diagnosis of mild cognitive impairment, whereas dementia requires loss of independence with daily activities. This is really a diagnosis in and of itself. It's not simply early dementia, because some people with mild cognitive impairment do not progress to dementia. This is a very active area of research where we are still trying to figure out, like, what is this condition, mild cognitive impairment? But I would say that a large majority of people with mild cognitive impairment do progress. Most people with mild cognitive impairment do have early Alzheimer's disease, but not all. But, regardless of what the etiology of their mild cognitive impairment is, these are the addressable, fixable things that we can do in primary care, the MCI actions, which is reducing alcohol intake, wearing hearing aids, treating sleep apnea, treating depression. These are things that, are well within our primary care wheelhouse, that we counsel people about all the time, where we really can make a difference. And so I want to take a second just talking about terminology a little bit, because you will sometimes hear these things called reversible causes, which is not wrong exactly, but I think it's not exactly as accurate as another term might be, which would be fixable causes, because a lot of times people have mild cognitive impairment and one of these comorbidities where you're not going to completely reverse their cognitive impairment. What you're going to do, though, is you're going to be able to address that comorbidity, which should improve their brain health. but I would caution about thinking of this as like, oh, now we found this thing, now we've reversed it and we're done. And so I really would think about fixable causes, or maybe even the best term of all is addressable causes, easily addressable causes that may be coexisting with a neurocognitive disorder that could be Alzheimer's disease. So we're not going to reverse their Alzheimer's disease with making these interventions, but we can easily address some comorbidity problems that are making their Alzheimer's disease worse. So this is the brain health checklist that I recommend, using for any newly diagnosed patient, because this is, while somebody may be waiting the months and months to get in to see a specialist, or maybe they sort of are like, heck no, I'm not going to go see a specialist. And, you are the caregiver, you are the medical caregiver. These are the things that we really can sort of address and make a plan for a newly diagnosed patient with, exercise, cognitive stimulation, social engagement being incredibly important for somebody with newly diagnosed mild cognitive impairment. All right, and so I want to share with you that there's going to be no GM Insights in October, and so the next session is going to be in November with the wonderful Stephanie Viverberg.
Thanks, Barak. That's awesome. I really love this framework of moving from reversible to fixable to addressable. I'm going to ask a question or two while we're waiting for some questions to come into the chat. First of all, it is morning. You're not wrong. Where you are, it's morning. We've just hit afternoon here, and so no points off on your assessment there. So one thing about alcohol that I find interesting is that people's intake may be the same, or it may be different because of circumstances. And so let me give you a little anecdote. I was talking to somebody who the four of them would share a bottle of wine with dinner. And I'm sort of doing the math in my head. And okay, so, maybe when you were 50, that was okay. And maybe that when you were 70, as I dig a little bit more, it's like, well, the kids have moved away. So the bottle of wine that we share is actually the two of us.
Right.
And one of those two people has wanted to cut down drinking. So that ends up being, for the person that you're talking to,
Yep.
3/4 of a bottle of wine versus one. I was just wondering how you there's plenty of standardized ways to assess intake and look at alcohol. But what are some of the tricks that you've learned and things that have gotten you to the right information?
Right. I think the other big pitfall is, when people are talking about like spirits or hard alcohol, because a drink like a gin and tonic for one person is not a gin and tonic for another person. You do really need to talk about, what is a shot, and so I really talk about, one shot of spirits is the same as 8 ounces of wine is the same as 12, your standard 12-ounce beer. And like those three things are roughly the same amount of alcohol. And we should be talking about each one of those things as a drink. And so if you are putting 3 shots of gin in your gin and tonic, that seems like it's 1 gin and tonic, but it's actually 3 drinks. It's the same as 3 beers. And so I really do sort of, I write that out for people. And I sort of ask them, so tell me about like a typical day for you, how many beers, how many 8-ounce glasses of wine, and how many, single shots of spirits are you taking, are you drinking? And yeah, I think that is a really important way of kind of framing. I really want to get a sense for what is a typical day for you.
I don't want to call out certain family members in my own family, but some gin and tonics, you have to talk to the person making the drink to actually understand what's in the drink. And I found that out the hard way after a couple of lovely cocktail hours and figuring out that it wasn't what I thought. I'm going to go to a couple of questions that we got in the Q&A. I'll read them out loud in case you can't see them, and I'll read them out loud for people who are listening and can't. Ashley Varner, thanks so much for attending. And here's your question. We are exploring embedding behavioral health clinicians, licensed counselors, social workers, etc., in some primary care practices to work with care partners and caregivers of those with MCI and dementia. Interventions would be around caregiver skill building and avoiding caregiver burnout. Is anyone familiar with any PCP practices and programs that have tried this? Thanks, Ashley.
Yeah, and I think that is absolutely the million-dollar question. I think, I also have had amazing experience using that integrated behavioral health model for depression. And I think has been incredibly, really transformed the way that we treat depression in the primary care setting. And I think that there's no question that it really should be, ought to be, a way that we also help with mild cognitive impairment and dementia. I think that the place that I think has probably published the most on this is a group at Indiana University. So they have what they call their brain health navigator model, which is maybe not exactly sort of applicable to all health settings because they really are focusing on RNs for that role. But I think that kind of embedded, integrated process within primary care is absolutely the way of the future, and I'm so glad that you are considering it.
Thanks, Ashley. It's always good to, get a pulse of what's going on everywhere else. We got some great models of care here. Barak is doing great work out in the University of Washington. And yeah, there's a number of different other programs that might fit those niches. We've got a great question from Dr. Anna Merck, who is our Geriatric Fellowship Program Director. Any advice on getting people to reduce marijuana use? It seems very persuasive, especially in rural older adults. I'll see. And I'll also just throw on to the end of her question a tag about things that people might not call marijuana, but gummies.
Yep. Yeah, and so I again I have been asked about this question enough that I kind of sort of did weave it into my talk because it's really not enough to talk about just alcohol anymore. I think the number of people in their 70s and 80s who are using marijuana, either smoking it or ingesting it, is pretty high, and I think that it's hard to say that there is not a very similar effect on cognition from those two ways of using marijuana. That I think really I would frame it in the same way as the alcohol, where I sort of understand that you have been smoking or ingesting this amount of marijuana for years, and it seems to have been fine. But the phrase I use is, if we really want to do what we can to make your brain healthier and make it work better, I really can say with a fair amount of confidence that reducing the amount that you smoke or reducing the amount of gummies that you eat really will help to clear your head and make your brain work better, improve your memory. And I use this with alcohol as well, where it's like it's not like you must never touch another drop of alcohol ever again, because you're definitely going to lose people if you kind of are that draconian. But you really can say that by reducing the amount, you really can make a big difference. And I really also want to focus in on how people with mild cognitive impairment will forget sort of how much they have ingested. And so I have definitely sort of run into the situation where somebody has a gumi and then sort of 30 minutes later, they don't remember that they sort of ingested that gumi. So they ingest another gumi, and you can definitely end up with an overdose. And so I really do emphasize how importantly careful it is to be, not, that applies to their medication sort of administration as well. Did you take the pill or didn't you take the pill? But I think really also thinking about, did you ingest that gumi or didn't you ingest that gumi? I had an amazing conversation with one of our addiction specialists here last weekend, where she does a really wonderful, innovative sort of program with monitoring methadone use in people using like a text-based sort of reporting, and they are definitely experiencing people in their 70s who are on opioid replacement therapy with methadone, who are sort of like recording 30 minutes later that they are taking their giant dose of methadone again 30 minutes later. And so I think that really, especially with cognitive impairment, it's really important to sort of to lay that sort of caution about, is somebody kind of on top of how much they're ingesting.
Brock, we got a couple of questions that'll finish this up. One is from Pam Laura Culler, one of our primary care providers and medical education leads here. She says, I recently referred a patient to neurology and it was revealed that he was drinking excess caffeine, 8 cups of coffee and 4 cups of tea a day. Cutting this significantly improved his symptoms. Do you find it useful to ask about caffeine in patients with memory loss?
Oh, that's a great anecdote. I love that one. Which is absolutely, like, you will be surprised at, so that is not something that I have like typically sort of included on the checklist. I will say that, the cognition checklist that I showed you is really, really focused on making it as absolutely sort of concise and sort of whittled down to the very, very top things, just because primary care is so busy that it's hard to sort of like think about all the things that you could or should ask about. But for sure, somebody who's drinking that much caffeine is going to be worsening their anxiety, and is going to be maybe even worsening their depression, and that is going to for sure impact their cognition.
I got questions keep coming in, and that's great. Chad Hales is one of our directors of cognitive neurology here and one of the GMN leaders. And so he asks, the concept of MCI, mild cognitive impairment, requires a symptom and an objective measure of cognitive impairment. Some patients may not do as well on the MoCA and could fall below 25, but may not have MCI or decline. We are struggling with this issue in the framework of amyloid monoclonals, which requires an MCI or mild dementia diagnosis. This issue will become a moot point once we have preventive therapies, but will your model end up identifying some people who may not be appropriate for the current treatments, monoclonal antibody, anti-amyloid?
Yeah, and that is such a great question. And here I sort of bring us back to, these 3 components of the cognitive evaluation, which is that, it's not a MoCA test alone, and it's not an interview with the patient family member alone. It really is putting these 3 things together, and that's like, I think the art of medicine. It's the art of primary care. This is like the stuff that we are sort of great at in primary care, of dealing with some diagnostic uncertainty, where you really do want to make sure that you're looking at more than one potential domain for your assessment.
If you haven't used the MoCA before and you're in the primary care setting, there is a free training program. I've had a lot of experience with the MoCA and been corrected a lot of times, but the training program sounds really great as well. A couple of quick questions to finish this up. Chad Hales again, I thought the wine conversion was 4 ounces of wine and 12 ounces of standard beer and 1.5 ounces of liquor. I asked Google, and Google said the standard drink equivalent is 12 ounces of 5% ABV beer. If you are a beer aficionado, you'll recognize that the ABV on beer dramatically differs depending on what you're drinking. In a place like Washington, you probably state of Washington, you probably know about that. 5 ounces of 12% ABV wine and 1.5 ounces of 40% ABV distilled spirits. So we're in the right ballpark. But yeah, 4 ounces of wine, 12 ounces of beer, 1.5 of liquor. It's 5 ounces of wine. Chad just that 1 extra ounce there, but we're in the right ballpark. And Carolyn Clevenger, to finish this up, the director of our integrated memory care program, along with Laura Metters. I really like your materials for PCP practices that I saw at Gerontological Society of America last year. Are these available online or through other means?
Thanks for the prompt, Carolyn. Absolutely, yeah. So if you go to our website, cognitionprimarycare.org, you can download a lot of the materials that I've sort of referenced here, and they're free and they're available at cognitionprimarycare.org.
Barak, thanks for your national leading work in this area. Really appreciated your getting up for our lunch hour for your early morning to come on. We look forward to seeing you out here when you travel to Georgia later to visit with us. Thanks so much. We'll let everybody go, and we'll hang out for just a minute more. Thanks again.